Good morning all. Myself Dr. Gaurang Assistant Professor in Department of Orthopedics in Government Medical College, Surat. These topics are carpal tunnel syndrome, pulled elbow, trigger finger and the DUPUYTREN'S contracture. First we'll see carpal tunnel syndrome. So contents will be what is carpal tunnel, what is carpal tunnel syndrome, and the symptoms, causes of its treatment and exercise for carpal tunnel syndromes. So what is carpal tunnel syndrome? It is a narrow passageway of ligaments and the bones at the base of the hand. It is occupied by median nerve and its tendons. How it is formed? Scaphoid tubercle and trapezium is placed radially. Hook of hamate and pisiform ulnarly. Transverse carpal ligament palmarly. Proximal carpal row dorsally, which making floor, and the tunnel is narrowest at the level of the hook of the hamate. What are the contents of the carpal tunnel? There are 9 flexor tendons, one nerve, that's the median nerve, and flexor pollicis longus, which is the most radial structure. Now what is carpal tunnel syndrome? It's a compressive neuropathy of the median nerve at the carpal tunnel. You see the compression as in diagram it shows as compression at the wrist, which results in numbness and the pain in the hand. Then what are the causes of carpal tunnel syndrome? There it could be congenital predisposition, sprain or the old fracture at the wrist, hypothyroidism, rheumatoid arthritis, mechanical problem in wrist joint, work stress, repeated use of vibrating hand tools, fluid retention, bursitis, tendinitis, and this space occupying lesion which causes compression at the tunnel. It could be a cyst or the tumor. So what will be the symptoms? Patient will complain of the numbness and the tingling in the radial 3.5 of the digits, clumsiness in the hand and the pain and paresthesia that awaken the patient at the night. So how will we see physical examination? There will be a thinner atrophy of the muscles as seen in diagram. Second is the carpal tunnel compression test, also called as Durkan's test, which is the most sensitive test to diagnose the carpal tunnel syndrome, and it is performed by pressing thumbs over the carpal tunnel and holding pressure for 30 seconds. Onset of pain or the paresthesia in the median nerve distribution within 30 seconds is a positive result. Second is the Fallon test. Wrist volar flexion against gravity for 60 seconds produces symptoms. The less sensitive than the Durkan's compression test. So we routinely use the Durkan's compression test. Next is the Teniel's test, that is a provocative test which is performed by tapping the median nerve over the volar carpal tunnel, and it will give like electric shock like current like signals in the hand in the medial nerve distribution. So how will you diagnose it? In imaging part, will radiographs will help? No, there is no role of radiographs in diagnosing carpal tunnel. So what will be the diagnostic criteria? It will be numbness and tingling in the median nerve distribution, nocturnal numbness, weakness or atrophy of the thenar musculature, positive Teniel sign, positive Fallon test, and the loss of 2-point discrimination. We routinely see weakness and atrophy, nocturnal numbness, and the numbness in tingling in the median nerve distribution. So what will be the treatment? If we see the non-operative or the conservative treatment, that it could be a non-steroidal anti-inflammatory drugs, night splint, and activity modification. But in whom you can advise it? The indication is if it's the first line of treatment. Modalities could be the night splint, which is good for patient with nocturnal symptoms only, and activity modification, which avoid aggravating activity. Second is steroid injection. Indications will be the adjunctive non-operative treatment, diagnostic utility in the clinically and electromyographically equivocal cases. What will be the results of it? The outcome shows 80% have transient improvement of the symptoms, and failure to improve after injection is poor prognostic factor. So if patients will NSAIDs, if you have prescribed medicines and patient is not still improving, then we can go for steroid injection as it is adjunctive therapy. And patients who don't improve with the steroid injection, will have to see for surgery. Operative treatment is carpal tunnel release. Indications are the failure of the non-operative treatments, which is steroid or conservative trial. Temporary improvement with steroid injection is good prognostic factor that the patient will have a good results with surgery also. And in acute carpal tunnel syndromes following open reduction and internal fixation of the distal radius fracture. In these cases also, carpal tunnel release is must. So we'll see the outcome of the operative treatments. There will be pinch strength will return in 6 weeks. Grip strength is expected to return to 100% preoperative level by 12 weeks post-op. Rate of continued symptoms at more than 1 year is 2% in moderate and 20% in severe carpal tunnel syndrome. So few patients may not improve, few may have recurrence, and that's ratio is around 2%. Second will be full elbow. So contents will be the introduction of it, epidemiology, pathophysiology, presentation, physical examination, imaging, differential diagnosis, treatment, reduction techniques, and the complications. So we'll see the introduction first. It's also called as nursemaid's elbow. This common injury of the early childhood that results in subluxation of the annular ligament due to a sudden longitudinal traction applied to the hand. Sometimes parents hold the child like this. This horizontal, thus vertical traction will lead to subluxation of the annular ligament from the radial head. Treatment is usually close reduction with either supination or a hyperpronation technique. So, epidemiology part, its incidence as are common, and if we see demographic, then it's most common in children from 1 to 4 years of age. Average age is 28 months, and the rate after 5 years of age is rare. Slightly more commonly seen in female child. The pathology part, sudden longitudinal traction applied to the hand with the elbow extended and forearm pronated will lead to annular subluxation. It may also be caused by a history of fall. So in this, annular ligament becomes interposed between the radial head and the capitulum. In children 5 years of age or older, subluxation is prevented by a thicker and stronger distal attachment of the annular ligament. If you see the prognosis, excellent prognosis is there when reduced in a timely manner. How patient will present? Patient will give a history of click which may be heard or felt by the person pulling the child's arm. Symptoms are child refuses to use the affected limb and holds the elbow in slight flexion and forearm in pronated with the other hand. In the physical examination, there will be a pain and tenderness localized to the lateral aspect of the elbow. Range of motion will be full flexion and extension is possible, but pain will be there with supination. If we see imaging, radiographs are usually not required in the setting of classic presentation of the history of traction injury. If patient is a child who is 5 years or younger, there is consistent clinical examination. When obtained, elbow radiographs will be normal. So, this is not indicated usually. And if it's obtained, then 25% will show radiocapitular line slightly lateral to the center of the capitulum. If we see the ultrasound, it is indicated to help in confirming the diagnosis when it is necessary. When the mechanism of injury is not evident, when physical examination is inconclusive. Sometimes patient's relatives or parents don't know what happened to the patient, and the child is very young, and in painful condition, so he'll not speak anything. In that condition, you can go for ultrasound. So benefit will be no radiation to the patients, and it can visualize soft tissues also. We can see increase in echo-negative area between the capitulum and the radial head, which indicates subluxation, and sensitivity is 64.9% and specificity is 100%. It's quite useful. If we see the differential diagnosis of it, then if painful elbow is with limited supination, then it could be traumatic causes like a supracondylar fracture, olecranon fracture, radial neck fracture, lateral condylar fracture, or the contusion. In the infection, septic arthritis can also cause similar symptoms. In congenital conditions like radial head dislocation and forearm synostosis. there is also limited supination. You see the treatment part. In a non-operative treatment, there will be a close reduction of the annular ligament subluxation. The C indication that it can be treated in majority of cases. It must be certain no fracture is present prior to the manipulation. So it should be confirmed first. In operative treatment, open reduction is rarely required, and it's required for chronic cases and symptomatic subluxation that cannot be reduced. If patients came with more than 12 hours, 10 hours, 24 hours, and parents has noted it that patient is having some problem in his elbow, then yes, we have to go for operative treatment. We see the reduction technique. So close reduction of annular ligament subluxation. There are two techniques, supination technique and the pronation technique. While holding the arm in supinated, the elbow is then maximally flexed. The physician thumb apply pressure over the radial head, and a palpable click is often heard with reduction of the radial head. In a pronation technique, it involves hyperpronation of the forearm while in the flex position of the elbow. If we see the follow-up, child should begin to use the arm within minutes after the reduction, and immobilization is unnecessary after first episode. As soon as you reduce, child starts crying, and after 5 to 10 minutes, once child is come down, you can see that child can use his arm maximum he can. So what are the complications of it? It could be a recurrence, may occur especially if child is younger than 3 years, and initially it could be treated with cast application in flexion and neutral or supination position. So in initial cases, if it is treated with cast and immobilization, recurrence may occur. Next we will see trigger finger. Its contents are the introduction, epidemiology, pathophysiology, associated condition with it, prognosis of it, classification of trigger finger, how it present, how to examine it, what are the imaging requirement, what are the differential diagnosis of it, what is different treatment of it, and what are the complications. First we will see introduction part. So trigger finger is the inhibition of smooth tendon gliding due to the mechanical impingement at the level of the A1 pulley that causes the progressive pain, clicking, catching, and the locking of the digit. You can see here in the diagram, there is A1 pulley at the metacarpophalangeal joint. So here that could be swollen of the pulley, or that could be a malunited fracture which causes restrict the smooth gliding of the tendon. So pathology will be seen at the A1 pulley. If we see the incidence and 2 to 3% of general population is involved, 10% of diabetic population are more prone. So demographically, it's more common in diabetic and more common in females older than 50 years. Location is commonly seen in ring and long fingers, are the most commonly involved in adults. Diabetes is a risk factor. If we see the pathophysiology, mechanism, it's caused by the stenosing tenosynovitis at the A1 pulley, as I already mentioned. The pathophysiology is the fibrocartilaginous metaplasia of the tendon and or the pulley. There will be a proliferation of the chondrocyte, increased type 3 collagen, chronic hyperglycemia that creates collagen cross-link and which impairs the collagen degradation. In the pathoanatomy part, there will be occasional pathologic nodule of the flexor digitorum profundus tendon. The flexor digitorum superficialis is often unaffected. So, major involvement is the digitorum profundus but not the superficialis. A triggered thumb may have a fourth pulley, that's a variable annular pulley. It's causing stenosis in up to the 75% of the patients. Associated conditions, there are two types of it, orthopedic or the medical condition. In orthopedic conditions are the rheumatoid arthritis, calcific tendinitis, septic tenosynovitis, and the carpal tunnel syndrome. If we see that more than 60% patients with trigger finger have clinical or electrodiagnostic evidence of the carpal tunnel syndrome. So they are simultaneously involved. Medical conditions are the diabetes, in which there will be involvement of the bilateral hand and the multiple digits involvement is more common. Second is amyloidosis, hypothyroidism, sarcoidosis, gout and pseudogout. Prognosis: if patient is having a natural history of disease like a progressive symptoms beginning with pain over the A1 pulley and progressing to a fixed flex digit, then prognostic value is favorable. And survival with treatment will see that there will be relief with injection alone is achieved in up to 90% of non-diabetic patients. And relief with surgery is achieved in more than 90% of patients. Classification is given by green. Grade 1 is palm pain and tenderness at A1 pulley. Grade 2 is catching of the digit. Grade 3 is locking of digit passively correctable, and grade 4 is fixed lock digit. Presentation: how patient will present. Symptoms will be usually progressive symptoms. Pain at the level of A1 pulley, and patient start feeling of clicking, catching. Finger becomes locked in flex position at the interphalangeal joint and may have referred pain to dorsal metacarpophalangeal or proximal interphalangeal joint. So patient may have referred pain also. Sometimes patient complains that pain at the dorsal region of the metacarpophalangeal proximal interphalangeal joint. But when you examine patient and see overlarly, then we find out that patient is actually having his trigger finger. Physical examination: in palpation, there is a tenderness at the level of A1 pulley. Palpable nodule of the flexor tendon may also sometimes be palpable. If you see movements, then triggering with digit flexion and extension. Whenever patient extend the finger from the flexion position, we'll see the triggering. Fixed flexion of the PIP joint is also noted. If we see the provocative days, then flexion and extension of the digit may reproduce symptoms. If you ask patient to flex and extend the finger, patient may start pain at the A1 pulley region. Same imaging. Does radiographs help in diagnosing trigger finger? It's no. Radiographs never help to diagnose in soft tissue T. Then what are the differential diagnoses with trigger finger? It could be a joint contracture which is differentiated by the history of trauma and inability to passively extend the digit. And the second thing is pyogenic flexor tenosynovitis, which is differentiated by signs of infection. That could be a fever and could be elevated inflammatory markers, could be a raised total leukocyte count, like that. In the treatment part, non-operative treatments are splinting, activity modification and the NSAIDs, which gives relief up to 40% to 97% of cases. If we inject corticosteroid locally, that it can give relief of up to 60% to 90% of cases. In diabetic patients, we will use it less likely, and there will be a poorer response associated with longer duration of symptoms with corticosteroid injection also. Operative treatment indication is failed conservative treatment. Success rate is more than 90%. Use of ultrasound may provide higher success rate, higher recurrence in diabetic patient, and potential earlier return to work compared to open release. So what will be the complications? It's a radial digital nerve injury while putting an incision and cutting the A1 pulley. Post ringing by damage of A2 or A4 pulley. When we do dissection by mistake or heterogeneically, we injure A2 or A4 pulley, and there will be no restriction of tendon to the bone, and it will make a deformity like a bowstring. Wound dehiscence also, scar tenderness, and the stiffness may also rise. Next is DUPUYTREN'S contracture. It's a contracture of the palmar aponeurosis and characterized by the flexion deformity of one or the more fingers due to thickening and shortening of the palmar aponeurosis. The cause is still unknown, but hereditary predisposition has been established. There is increased incidence has been noted in cirrhotic patients and epilepticus patients which are on sodium hydrangeal. See the pathoanatomy. Normally the palmar aponeurosis is a thin but tough membrane lying immediately beneath the skin of the palm. Proximally it is continuation with the palmaris longus tendon. Distally it divides into slips, one for each finger. You can see in the diagram. The slip blends with the fibrous flexor sheaths covering the flexor tendon of the finger and extend up to the middle phalanx. The aponeurosis or a part of it becomes thickened and it starts slowly contracting, and which causes a drawing of the fingers into flexion at the metacarpophalangeal and proximal interphalangeal joint, resulting in the deformity. You can see here in dependent contracture there will be flexion deformity at the proximal interphalangeal joint. But if we see ulnar neuropathy, patient will have a deformity at DIP joint. So clinical features will be in early stages. There will be a thickening of the palmar aponeurosis. It will be felt at the bases of the ring and little finger, and in later on cases, and after it, patient will start flexion deformity of the finger as it develops, and only seen in the metacarpophalangeal and proximal interphalangeal joint, as I already mentioned. Treatment is in mild cases does not improve or need any treatment, and in significant deformity which hampers the activity of the patient, in that excision of the palmar aponeurosis is needed. So in significant deformity which hampers, what will be significant? The patient will be have difficulty in putting his hands in pockets, difficulty in combing his hair, difficulty in holding something and putting some objects to the floor or the table, like that. Thank you.